All right. Well, thank you very much for the introduction. I want to thank everybody for joining us. It seems like a pretty good turnout. I know we are streaming live as well, and so I want to thank everybody who is joining us in the virtual world as well. It's kind of exciting to be able to stream this as well as present it live to you all. Like Seth was saying, our facility down in Lakeview, this is a picture of it actually, and Seth had talked a little bit. This is the 10,000 square foot health and wellness center that we have with the track running up top and then all of the gym equipment on the bottom floor here. And like Seth was saying, we have our professionals group, which we run in the conference center right here. And weather permitting, we'll have the group outside, which is a nice little luxury, although if we had the group here, I don't think we'd be having it outside with the snow today. I was telling somebody before I came, I was so thankful I checked the weather because it was about 95 degrees in Jacksonville. And right before I got on the plane, I was checking the weather, and I'm like, oh, man, it's 30 degrees in Denver? What am I doing? But either way, I'm happy to be here, and I'm happy to present on this. And I will try and kind of pace through it at a reasonable rate. That way we have the opportunity to get to the entire presentation. We'll have time at the end. If anybody has any questions, I'll stick around afterwards. I'm sure we'll have time, and I'll be able to answer anything that you guys have. So again, my name is Philip Warrick, and I'm an LMHC. Got my undergrad from the University of Central Florida in Orlando and my master's degree from the University of South Florida in Tampa, Florida. For those of you that don't know, they are rival schools in football, and so I got a lot of grief when I transitioned from UCF to USF, but that's okay. Professional experience, I've worked in the field of addictions for about 6 or 7 years now, 6.5 years. And I am in recovery myself, and so I've lived both sides of it, and I'm happy to be here in the position that I'm at in a healthy recovery for myself. I do specialize mainly in addiction and recovery, and I've been at Lakeview Health for about 3 years and 3 months now. So the cool thing too is I was there before we went gender responsive, and I saw it, and then I was there when we went gender responsive, and so I'll be able to talk about those differences that we saw. So the overview for today. We're going to focus on understanding gender. We're not going to spend a whole lot of time on that. Hopefully everybody has a pretty clear understanding of gender differences. We will touch on it briefly. The goal is not to get in an argument about what gender is or how we define gender. We're just really going to focus on the fact that if we recognize that gender differences exist and we can individualize people's or patients' plans to work with those gender differences, then we get better outcomes. And that's the main reason we went gender responsive at Lakeview, and the benefit of it continues to show itself on a daily basis. So again, we'll define gender responsive treatment. We'll look at the difference between gender responsive versus just gender specific, because there is a big difference between that. We'll look at gender differences in treatment, and then lastly, we'll go over the practical application of gender responsive treatment. Common questions that people ask is always going to be that transgender population, and how do we deal with that in a gender responsive program, and we'll be able to get to that and have a little discussion about it if we have time. If not afterwards, we can definitely talk about it. We'll talk about the treatment curriculum. Stephanie Covington, I'm sure a lot of people are familiar with Stephanie Covington and some of her work. We use her curriculums as part of our programming. And then lastly, like Seth touched on, we'll talk about trauma as well and trauma therapy. So again, to start off with gender, we have the gender-bred person. The state of being male or female, the definition of gender, typically used with reference to social and cultural differences rather than biological ones. So we can see all the ways in which we define gender. You have gender identity, gender expression, the biological sex, the sexually attracted to, and the romantically attracted to. So there's all different kinds of, there's a vast array of differences when it comes to gender when we talk about gender. And again, this quote kind of sums it up best. The role of culture is not zero, and the role of biology is not zero. What the research shows is that if we identify and we focus on those gender differences and we come up with individual plans for each patient, the outcomes are going to be substantially better. And again, that's the whole reason behind going gender specific in our programs, or gender responsive, in our programs at Lakeview Health. So why gender? We chose to present on gender considerations in addiction treatment for a few different reasons. One of the big ones being the industry change. We've seen that since probably the 1960s up through today. We've seen it slowly migrating in this direction, very slowly migrating in this direction, but still migrating in this direction. And then like I touched on earlier, personal experience. gender separation on campus. What have I seen from when we were co-ed to gender-specific now, and how those differences have kind of played out, and the advantages of having the gender-specific or gender-responsive treatment programs at Lakeview. So here's the paradigm shift that we've seen over the years. In the 1960s, you had non-specific treatment, mixed genders in pretty much every treatment facility. We didn't recognize we recognized that there were gender differences, obviously, but we didn't recognize the impact of those gender differences in treating addiction. In the 1970s, we start to recognize some of those differences and why it's important to have separate the genders in treatment. It wasn't until the 1980s that we actually started to see that separation in treatment centers. We started to see males and females being separated in treatment programming. But again, this was just gender specific. It was not gender responsive at this point. So basically, you're running the same curriculum, you're running the same programming, you're just having the genders in separate facilities. And then it was in the 1990s and into the 2000s that we started to see the gender responsive. So this is when you start to really individualize the plans for the different genders, and you're focusing on the issues, the core issues that females are facing versus the core issues that males are facing, and you're coming at it from different angles depending on the gender. And so you can really start to create a curriculum and a program that's centered around the specific challenges that each gender faces in recovery, and when they were in active addiction, of course, as well. And then Lakeview Health, actually, we went gender responsive in June of 2016. So we've been gender responsive for just about 3 years now. And again, I'll talk about all the benefits that I've seen personally of being able to do that. This is Stephanie Covington. Is anybody familiar with Stephanie Covington? I'm sure some people are. So Stephanie Covington is one of the leading researchers when it comes to, she started out doing just women, treatment and addiction for women. She came up with the Helping Women Recover programming. And then, I cannot remember the exact year, but about 15 years after she started her research into women, she started incorporating men into her research too. So now she has the Helping Women Recover and the Helping Men Recover curriculums. I'm going to talk a little bit about those two curriculums throughout this presentation. We use those curriculums at Lakeview Health. We run programming twice a week on Wednesday and Friday, where we actually go through one session each day through this programming. And again, I'll have more time toward the end to kind of talk about all the topics that are covered. But it's 4 modules. Each book is 4 modules, and it covers self, relationships, sexuality, and then spirituality. And so it can be a pretty intensive curriculum. But it really starts to dig at a lot of the core issues that a lot of people in treatment are facing, specifically related to their genders. So gender-responsive treatment. Fostering a safe environment by focusing on the following. The physical location, the quality and training of staff, programming, and curriculum. In order to tailor treatment to meet the individualized needs of men and women, while focusing on their unique strengths and challenges. So again, this is a very strength-based approach. And we're going to go through each one of these talking points: physical location, quality, training of staff, making sure that the entire staff is trauma-informed so that when providing care, we understand the challenges that some of the patients will be facing as it relates to their trauma. And this doesn't mean just the clinical staff either. We train the entire staff, so everything from the kitchen staff to the house cleaning staff on trauma-informed care, because we know how big of an issue and how important trauma-informed care is, especially early on in early recovery, trying to avoid triggering anybody. So the principles of gender-responsive treatment. Gender is obviously the big one. Then you have environment, relationships, integrative services, economic and social status, and then community. We're going to go through each one of these different points here. So for gender, accepting that gender matters and that ignoring gender-specific issues while in treatment can put patients at a disadvantage. And I've already talked a lot about why we have the split genders at our treatment center. But again, the main thing is that whatever your belief is on it, accepting the fact that the gender differences play a role is the key. That recognizing that gender differences are an important part of dealing with the addiction and individualizing a patient's plan is what's so important. And that's why at Lakeview, when we have the gender split, what we're doing at the women's side is going to be very different than what we're doing at the men's side. The topics that we discuss can be very different on the women's side than what we're talking about on the men's side. Obviously, there's a lot of overlap as well, but there's going to be pretty big differences. This is a cool slide. I like this slide a lot because this is talking about the environment. Building a treatment environment that prioritizes safety, respect, and dignity for all patients. So what we have here is on the right, we have kind of an intake room at a hospital or potentially even a corrections facility or something like that. And we can see the colors. We can see how every chair is facing the same direction. Does that foster a safe environment? Does it feel like a place that you would want to go into and to accept help from? Probably not, right? It doesn't look very welcoming at all. Well, here's a picture of the Rose facility, the Rose welcoming room. So when you walk into our facility, you'll see the bright colors. You'll see the pictures on the wall. You'll see even the smell. We'll have a specific smell at the intake room at the Rose. This is providing each patient with that safe environment that we want to foster throughout their stay. Every little detail of the environment is going to be tailored to the specific gender. On the next slide, so here we have a picture of what we see at the Rose facility. On the next slide, we're actually going to look at a picture of the men's facility. And this kind of relates to relationships. Making sure that the whole facility, everything from the policies, procedures, programming, helps to promote the healthy relationships with others. So this right here is a picture of our men's facility. What does this remind you of? For those of you, somebody said sports bar, right? It kind of looks like a Chili's or an Applebee's or something like that, right? And that's why we designed it like that. We designed it to emulate or to look like a regular sports bar, Buffalo Wild Wings or something like that, right? Because when these patients leave and they're reintegrated into society, they're going to be immersed in environments like this, and they have to be prepared for that kind of thing. And so this is the bistro. This is where they all are going to eat. This is where the men eat all of their meals. This is also about building relationships, right? You see how most of the tables are long and they all are forced to kind of sit together and talk with one another. We wanted to have that vibe, and we wanted to create that sense of community within our treatment center. And so that's why we designed this like this. Now, over on this side, we have our women's at the Rose. That's the manicure and pedicure and spa, basically. All right? And so the women have the opportunity to build relationships while they're learning about self-care and the importance of self-care. Okay? And so we have that available to them. And I think we have the manicurists come out once or twice a week now to provide those services. But while they're there, they're able to socialize. They're able to see what it's like to have fun and enjoy recovery, and realize that there are ways to enjoy recovery that don't require drugs or alcohol or anything like that, obviously. So we use integrative approach to treatment. Treating substance abuse, co-occurring mental health issues, and trauma concurrently and in an integrated way. So we see all the services that the treatment center provides when it comes to gender-responsive treatment: intuitive and creative, rational and scientific, practical skill building, psychodynamic, family of origin, and then of course that mindfulness, spiritual-based approach. And all those come together and create the integrative approach to services that we provide. But with this approach, this is where we can individualize the treatment for each patient. All right. So if somebody comes in and we identify that they have a significant amount of trauma, and maybe they're in a position where they're ready to start working on that trauma, we can integrate that into their treatment because we have trauma services that we can provide them. If they come into treatment and we recognize that they're a professional in the community, they're a mechanical engineer or a CEO or something like that, we can place them in the professionals group, and we can individualize their treatment that way. That way they're focusing on the specific challenges that they're going to have to deal with once they leave treatment. and into their aftercare. And so we use a really integrative approach to therapy that obviously is very beneficial to individualizing the treatment plan for each patient as they come into treatment. We have economic and social status. Pay attention to the ways that each gender can improve financial status by addressing occupational issues. So this could be very different depending on the gender. Oftentimes we will have women on the rose side who financially are being financially abused in their relationships. The husband or the boyfriend or significant other is using money as a weapon in the relationship. And so how do we deal with that? How do we come up with a safe plan for that individual so that when they leave our treatment center, they're prepared to take on that challenge when they leave? The guy's side can be completely different. They may be the breadwinner at home, or they may be the one that's bringing in all the money, but their life satisfaction's way down here because they're spending all their time at work. So how do we overcome that challenge with them and have them reprioritize what's important in their lives so that they get an increase in their overall life satisfaction and limit the rate of relapse as a result of that? So depending on the gender, they can be facing very, very different challenges when it comes to the economic and social status. And that's something that with a split facility, we're able to capitalize on and really focus on with each gender. Community. Integrate community involvement in a way that assists patients in feeling connected with the larger community during treatment. When a patient comes into a treatment center, specifically Lakeview, we're basically cutting them off from the rest of the world in a lot of ways. You know, when they're first here, they're going through detox, then residential level of care, and they don't have a lot of connection with the outside world, outside of some family visits and things like that. So what do we do in terms of a community with them? We have an ACG group, assertive community group, every morning, right? And so that's where we have the community-led group, where the community leaders and the co-leaders and the mentors can come in and talk about what's going on within the community. What issues are people facing? What's going wrong with the facility? What things do they think we need to change, or what things can we improve upon in our facility? They can bring all these issues up to the front and have a discussion about it as a community, and hopefully start to instill those community values within one another. And then as they transition further into the program and they go through our PHP and IOP levels of care, they'll be able to start reintegrating back into the outside community as well. So we'll take them to, I was mentioning to somebody earlier today, we'll take them to the beach, or we'll take them to some outside meetings, or to we have something called the Riverside's Arts Market in Jacksonville. It's a cool little market, and we'll take the patients to that. That way they can start experiencing the outside community and start building up support so that when they do discharge, they feel a lot more confident about reintegrating back into the communities that they come from, or whatever the aftercare plan is for them. If that's sober living, it's sober living, whatever it might be. But building a sense of community is incredibly important at both of our facilities. And that ACG group, that assertive community group, does a great job at allowing us to accomplish that, and for them to take ownership over their community, right? It's not all on us anymore. The community is responsible for maintaining it, right? And of course, with the help of therapists and the entire team. But they take more ownership over the entire community. So we have a quote here, and I'll just read it real quick. "It is dangerous at best and completely wrong at worst to assume that any neurological disorder has the same underlying causes in men and women, and thus to assume that treatments for the disorder will be essentially the same. Yet this is precisely the assumption that continues to pervade much of both the clinically applied and basic science worlds." So again, we are seeing this. We are seeing a change in this, but we still see how a lot of individuals who are seeking treatment are going to facilities around the country, around the world, and are not receiving that gender-specific treatment that is so key in terms of building a successful recovery for themselves. So we're going to look at all those. We're not going to look at all those differences. First, being substances used, because there are a lot of different substances out there, and we've seen patterns in what women tend to abuse versus what men tend to abuse. The disease of the progression the disease progression is different depending on the gender. The access and barriers to treatment are different. The detox process as a whole is different. The detox process affects genders differently. Co-occurring disorders. So at Lakeview, we're dual diagnosed. But what the men come in with in terms of mental health, it can be very different than what most of the women are coming in with. Social support, different stigmas, and then, of course, we'll look at trauma at the end here as well. So substances used. Men are more likely than women to use most drugs. Marijuana, we'll start with marijuana. The severity of use is higher in males, especially in Colorado, I guess. I'm from Florida, so we don't. Disordered use develops more quickly in females. So we'll actually see that. See the progression. Women go through the progression, progression of the disease a lot quicker than males will. Stimulants, so Adderall, Vyvanse, things like that. Women are twice as likely to seek treatment for methamphetamine and amphetamine abuse. Women are more likely to report using methamphetamine for increased energy and decreased exhaustion. Associated need with work, home care, child care, and family responsibilities. So this is that thing where we see women trying to work a job, maintain the family. They have 10 different hats they have to wear, and they're trying to keep up with everything. And we'll see the methamphetamine and amphetamine abuse. For opiates and opioids, women are more likely to abuse prescription opioids. Men are more likely to use heroin intravenously. Women, this is an interesting one. Women reported increased likelihood of using heroin over prescription opiates at the request of sexual partner encouragement. So this is when we start to see that power and control wheel come into play, which is a big part of the treatment process on both sides, actually. We use the power and control wheel pretty aggressively on both sides. Our experience, higher prevalence in treatment. This is for that come in with the opiates and opioid abuse. 62% of our men that come into Lakeview have an opiate addiction of some kind, whereas it's 46% of the females have it. And that could be with other things. It could be polysubstance as well, but they'll at least have the opiate. Alcohol. Men have higher rates of alcohol use in increased instances of binge drinking. Alcohol abuse results in unique risks for female drinkers, and a lot of these you'll see when we talk about the trauma that the women experience as well. Unprotected sex resulting in unexpected pregnancy, transmission of sexually transmitted disease, increased risk of becoming victim of violence, and increased risk of sexual assault as a result of that. The disease progression and prevalence. I talked a little bit about this a second ago. Women tend to begin using in lower doses, maybe due to tolerance or cultural norms. Substance use progresses more rapidly into dependence with women. Results have been replicated with laboratory animals in this one as well. But what we see is that men tend to prolong and avoid getting treatment, whereas women can get into treatment a lot earlier because you see the disease take over so quick. With alcohol, for example, for the progression of the disease, a guy could drink for 10, 15 years, whereas oftentimes a female the disease will progress in a couple years to where they're needing to seek treatment because of the addiction. Access to treatment. Women account for roughly 33% of the admissions that we see at Lakeview. And are more likely to be internally motivated. So they'll come into treatment more motivated to really start the work. Men, on the other hand, account for about 66% of our admissions and are more likely to be externally motivated. So that can be motivated by family, motivated because of a DUI and legal, motivated because of their job. But whatever it is, a big part of our men's side, a big part of their treatment is getting them to get to that point where they're internally motivated. So we focus a lot on how to develop internal motivation, how to foster that motivation so that they're able to build up a more substantial accountability system and find more success in recovery as a result of that. Although what's interesting now with our census at Lakeview, we're almost split. currently, which is kind of interesting. It's not typically like that, but right now we do have an increase in women in treatment. I mean, it fluctuates pretty rapidly, but barriers to treatment. So men, these are some common barriers, and I'm sure a lot of you have faced when dealing with a lot of the patients you serve. Men not feeling like they have a problem, so we call that just denial, right? Pre-contemplation phase. Perception they can overcome addiction on their own. And this goes to a lot of that progression of the disease as well. The perception that they can overcome addiction on their own, and so they'll try over and over and over and over again, different things to try and change the addiction. You know, cutting back, switching drugs, whatever the case may be, until they actually seek treatment. Belief that treatment is a sign of weakness. That's a real big one that we see with the guys pretty frequently when they first get into treatment. People are going to think I'm weak, or that I don't have any, I can't do anything on my own. And so we have to break down that barrier pretty early on, and hopefully get them to a point where they're more willing to accept the help and realize that asking for help is a sign of courage, not a sign of weakness. Feel that they are a functioning addict. But I go to my job every day, and I work 60 hours a week. How can I be an addict? But then you call the wife, and the wife will give you a whole story about abuse going on at home, or how he's always passed out on the couch and he doesn't spend any time with his kids. And so he's avoiding to talk about that part. He just wants to focus on what's working, not all the other areas of his life that are broken, right? Financial obligation to the family. We get that a lot. Patients who will come in and either not want to commit to a full length of stay, or who want to try and work from treatment, try and do all the, try and maintain their businesses or whatever the case may be. Oftentimes we find when they were in active addiction, they weren't doing much at their job anyway, if they are even able to maintain a job, and they're just using this as kind of an excuse to try and get out of going to treatment. We do have a professionals program, again, I've talked about it a little bit, at Lakeview. And if we get somebody who comes in who needs to have access to their computer to run a business or something like that, we'll work with them on that. But it's always on an individual basis, and it has to be a prior, like a need that they really need. We have our it's kind of funny, but we'll have our patient advocates or our social workers working with a professional who says he needs to be on his laptop for, I don't know, an hour or two a week or something like that. And you'll walk around, you'll look, and he'll be on Facebook or something. You're like, how important is this really? I don't think you need all the time you're getting. So anyway, we do monitor that kind of stuff, really important, because we want them to be focused on their recovery, obviously. And then that kind of goes into fear of damage to the career. For a lot of professionals that come into treatment, a lot of the men specifically, reintegrating back into the workplace. What's it going to be like? What kind of questions are they going to ask when I return to work? How do I prepare myself for some of those challenges? And the professional group does a great job at spending time talking about a lot of those things. Barriers cause men to seek treatment later in their disease. And again, that's what we talked about, that progression of addiction taking a little longer with the men. Barriers to treatment for women. Financial insecurity before and after treatment. Concern that children will be taken away as a result. That's a big concern for a lot of the women that come into treatment. What's going to happen with my kids? Is DCF going to get involved? There's all kinds of worries when they come in, and it can be a huge barrier for the women. And so we do a really good job, especially when they first get there, of assessing them and making sure that there's a plan in place to take care of all that stuff. To try and eliminate that barrier. A lack of adequate child care while in treatment. Inability to complete due to family responsibilities. Again, like I said, a lot of times the women are trying to wear a lot of hats at once. And being able to keep up with all those responsibilities in treatment can be difficult. That being said, if we honestly look at how they were keeping up while in active addiction, oftentimes it makes sense to spend the time now to get it. It always makes sense to spend the time now to focus on your addiction and recovery. That way you can be there in the long run to take care of the family, or to help take care of the family. And then co-occurring disorders. increased likeliness of suffering from co-occurring disorders that prevent women from seeking treatment. And I won't talk a whole lot on that right now because there's some slides later on where we talk about those co-occurring disorders and how they play a role in their treatment. So detox symptomology. Women more susceptible to cravings and thus relapse tend to be sicker and report higher levels of physical complaints from the physiological effects of addiction. So at our facility, like Seth had been saying, we do have a full medical staff, and so we do a full detox when they come into our treatment facility. And the detox that we do for the women can be very different than the detox we do for the men, depending on the severity and depending on obviously the drug of choice. But we want to make sure that we tailor it, one, to make sure that they're as comfortable as can be through that process, but to limit, like you said, that rate of that AMA rate. If we can make them a little more comfortable, make them or give them the time to get through the detox process, then they're less likely to run and relapse so that they don't have to feel it. Men, again, tend to metabolize chemicals differently and often more quickly than women's bodies do. As a result, the detox is going to be different for them. Co-occurring disorders. Men present with fewer co-occurring mental health diagnoses than women do. Oftentimes, the men are dealing with things like ADHD. You will get some depression. A lot of the depression is linked to self-worth or guilt and shame in the men. With the women, you have higher rates of anxiety, mood disorder. We see, especially at our facility, we'll see a decent amount of borderline personality disorder. I think some of the other personality disorders. A lot trauma, although I will say when we split the genders, I think Seth alluded to this, we saw that rate of trauma go up for the men because they are more willing to open up about it. A lot of the guys were hiding it or internalizing that trauma. If we created that safe environment, they were more willing to open up and start talking about the trauma. And then on the women's side, eating disorders as well. Although, interestingly enough, that's another one that we saw jump up a lot on the men's side when we split the genders. Because, again, they were more willing to open up and start talking about it. We have a dietitian at Lakeview that works with all of the patients that have the eating disorders and does a wonderful job with getting them on the right track. Social support. Women are less likely to have the support of family or partner to enter treatment. Women are perceived as being selfish for entering treatment. They're supposed to be at home taking care of the kids, or they're supposed to be helping financially, take care of the house and the family. However, men tend to receive more positive reactions from support network when considering treatment. Men are brave. Men are considered brave for entering treatment, right? So we see these two drastic changes, and we see why sometimes for women too, it's difficult to get them to commit to treatment and to taking the steps they need to focus on themselves as opposed to focusing on the family or focusing on other things, outside things. So this is interesting. When we talk about stigmas, if I was to Google mother drinking meme, what do you think would pop up? Mother drinking meme. Potentially, right? And so we see, you Google mother drinking meme, and you see basically what we've been talking about, right? The most expensive part of having kids is all the wine you have to drink. So it's all about being a mother and having to take care of kids and put up with different ways to put up with kids through drinking or abusing substances, right? And then what would you think if I Googled father drinking meme? What would come up? The good old boys, right? In a way, yeah. Right? We have Charlie Sheen. We have the most interesting man in the world. We have the gentleman from Mad Men. Thank you. Gatsby, right? So all these guys, alcohol is for people who can afford to lose a few brain cells. So it's a joke, and we can see the vast differences just from even Googling terms like that, right? How the genders play such a huge role, and how the culture and how society perceives addiction, right? So trauma. As children, boys and girls suffer similar rates of abuse. The type of abuse is usually different, though. So for girls, you have sexual abuse, boys, emotional neglect, and physical abuse. In adolescence, boys are at greater risk if they are gay, young men of color, or gang members. Young men, people who dislike or hate them. Young women, this is the abusers. Typically for young men, it's people who dislike or hate them that are abusing them. For young women, it's usually family or romantic relationships that are the abusers in those cases. So when you look at this, you can see why the approach to treating trauma is going to have to be different as well, right? They're experiencing different kinds of trauma from different kinds of people, and so the approach to treating that trauma is going to be very different as a result. Adult men and women tend to experience different types of trauma. So men, again, you have the physical violence and the grief and loss. Women, a lot of emotional abuse. Women retain emotional memories in a more vivid form than men do. Trauma prevalence. So this number is the total number of trauma. When we do an intake and we assess for trauma, about 95% of women are reporting trauma upon intake, and 50% of men are reporting trauma upon intake. That number went up a lot when we went gender responsive. However, what we do find about this prevalence number is that in men, it ticks up a lot higher than 50% throughout their stay, because they start to open up and they start to share and they start to realize that the things they experienced, what they categorize as maybe not being traumatic or not understanding what trauma was really actually a traumatic experience for them. And I won't go over all the statistics, but you can see the prevalence rates of all these different things. And again, you see the unresolved grief and loss for the men. A lot of the men that come in deal with that unresolved grief and loss. A lot of the men uncover the physical abuse and violence throughout their stay. As they're working the curriculums, helping men recover, there's a whole section where we talk about power and control. We talk about childhood violence, and that's when a lot of the guys start to realize the abuse that's occurred and the cycle, how it's starting to occur again in their lives as the abuser. And so how can we break that cycle with them? So when is someone ready to explore trauma? This is something that I talk about a lot. At Lakeview, we take people when they're day one from detox. I mean, they're coming in and still high, basically. And we're taking them through the entire detox process, into residential, through PHP, and then into IOP as well. And so how do we know if a person's ready to explore their trauma? Is everybody ready? If a person has experienced trauma, are they always going to be ready to start that trauma work? Absolutely not, right? And so we want to make sure that if we're going to work with someone on their trauma, that they're ready to start working on it. And a few of the ways we do that, we want to make sure that they have safe coping skills. They have no major crisis or instability. For example, if they just received divorce papers that day, it's probably not a good day to start working on trauma with them. We want to make sure that they're willing to work on trauma. We want to demonstrate the ability to ask for help when needed. We want the patient to be willing to ask for help when needed before we start working on trauma with them. Obviously, we don't want them to be using any kind of substances or reporting any suicidal ideations, and has consistency in the coming weeks. So we'll have support of the treatment team. We run trauma groups on both the men and the women's side, and we do use a curriculum for the trauma groups. However, there's a lot of psychoprocessing that goes on in those groups as well. We have therapists who are EMDR trained. However, we rarely use EMDR where we are because they're just not ready for that level of intensity with their trauma work. Now, if it's a patient who's come in, who's been doing some work with EMDR, and who we feel would benefit from it, we'll certainly consider it. But most of the time, we're really setting that kind of service up for aftercare to make sure that they're getting those needs met in aftercare. Really, we're building the foundation for that trauma work that's going to have to continue once they discharge. So real quick, I do want to get through the benefits of gender-responsive treatment. Building healthy relationships with peers of the same gender. Reduction in romantic relationships and treatment. I should highlight this one in red, because I'll tell you, when we were joint, I walked in on some very interesting things, and I'm happy that doesn't happen anymore. Discussing trauma and self-esteem issues more openly in gender-specific groups. More willing to open up. More willing to let the shield down and to show some vulnerability. When we were co-ed, you would always see the men using humor or trying to deflect, and the women just unwilling to open up and share it all. You don't see that when you go gender responsive. A focus on gender-specific needs that, again, are individualized. So, what are some of the observations that I personally have seen? So I wrote, since I'm the clinical manager of the men's side, I wrote these ones, and then Sarah Franklin, who's our clinical manager of the female side, we were both therapists on both sides for a couple years before we moved into our roles. And we were able to look at what we noticed, what we recognized when we went gender responsive. So on the women's side, take longer to connect with other women. But on the men, we saw a reduction in using humor to deflect. The fear relationships with other women. Most of my friends are guys. We saw a lot of that going on, not wanting to build relationships with other females early on. However, on the men's side, we saw an increased display of vulnerability, expression of different emotions. We started to see a sisterhood bond on the women's side and strong camaraderie on the men's side. Women participate more actively in groups without male presence. And in absence of women, men will take on caretaker role and support each other, which is something we're very careful about, too, because we don't want them to we obviously want them to support one another, but we don't want them to take on the role of a caretaker or focus too much on another individual instead of themselves. Less focus on personal appearance on the women's side. This was really interesting to see. Go from putting on the makeup every day to wearing the nice clothes, and then the second you go gender specific, it completely changed. Completely changed. On the men's side, you see a decreased sense of competition. Although I would take the guys to the basketball courts once a week, and there was still a pretty healthy competition between them. On the women's side, women tend to stay in treatment longer when it's gender specific, and same on the men's side. The AMA rate dropped a lot when we went gender specific. No more couples running off together in love. Instead, the men and the women were willing to stay and remain in treatment for the whole time. I only have a couple minutes left, and I was going to talk a little bit about the gender responsive curriculums that we use, but what I'll do is kind of go through them quick. Like I said, there are 4 key areas that we address in these curriculums: self, relationships, sexuality, and spirituality. So, for example, Module A, you have 4 sessions on self for the women and 5 on the men's side. When you're talking about self, the women's curriculum focuses on self-esteem, sexism, and stigmas, where the men's side is more about experiencing emotions and how to experience and deal with emotions in a healthy way. The B module deals with relationships. The differences is the women's curriculum spends a lot more time on mothers and interpersonal violence, whereas the men's side spends more time on fathers, communication skills, which we spend a lot of time on. A lot of men don't realize that they're being aggressive, right? And then barriers to healthy relationships. The sexuality module. The women's curriculum focuses on body image and sexual abuse, whereas the men's side focuses more to barriers to sexual health and defining sexuality. This is also where we integrate the power and control wheel. I'm going to skip that for now, but I'll talk about that later. And then the last module is spirituality, which again we start to develop an understanding of your higher power, or how to incorporate spirituality in some way into your recovery. So for the trauma groups that we run, again, we do use a curriculum. However, that curriculum is also integrated with some psychotherapy as well. And so we use the curriculum, but we also will allow them to explore the trauma. These are all the sessions. It's a 12-session curriculum. Again, I'm not going to go into detail about every single one of them. However, you can see it's pretty comprehensive, especially in establishing safe places, making sure that the coping skills are in place. We have all those things ready before we actually start exploring the trauma. And then these are just some examples of some of the tools that we use. One of the popular grounding skills, the 5 senses grounding skill, which I'm sure a lot of people are familiar with, that power and control wheel. Trauma group examples that they use. the letter writing exercise to the inner child can be a real powerful exercise. And then on the men's side, what does it mean to act like a man? This is where we get into like the that macho man stuff. What it means to be a man versus what it means to be in recovery, and how well do those things line up, right? So how do we integrate it into personal practice? Gender separation is not always possible. We want to recognize the relevance of gender-specific issues using a lens that is mindful of gender issues during assessment, asking the right questions, and then focus on approaching every client from a strength-based approach, identifying unique strengths and challenges that each individual, each gender, but also each individual is going to face in recovery, in treatment and in recovery. These are a couple recommended readings out there. A lot of this stuff, some of the Stephanie Covington stuff, but these are pretty good. Women in Addiction, Woman's Way Through the 12 Steps, Awakening Your Sexuality. Again, the sexuality on both the men's side and women's side is a big area that we hit on. There is a lot of sexual disorders that go undiagnosed in addiction treatment. And so we want to make sure we start the process of addressing those things with aftercare to follow up. And then helping men recover, again, is the one that I already talked about a little bit. So that is, in a nutshell, the gender-responsive treatment module. I apologize. I had to rush through it kind of quick here. But I will stick around for anybody that has any questions, and I'll be able to answer anything you guys have about our program or about gender-responsive programming as a whole. Especially if you have specific questions about what I've seen in my work, I'll definitely be able to answer those for you as we go. So thank you all very much. Yeah.